Good morning, everybody. Half of this dark side was already mentioned by Evangelina. But before I proceed with this issue, which is actually quite important, I need to say and how this lecture actually fits into this course, which is focused on aging, okay? Because somebody would ask why we discuss about these things in an aging course. Now, we know very well that diabetes prevalence is increasing as the age goes on, as we age actually, and actually more than 1/3 of the patients which have adult diabetes, the type 2 diabetes, they're above the age of 60. So they're between the age of 60 and 79 and probably older than that. We have this on mind, and then we also know very well that if you have the combination of older age and diabetes, is something quite difficult for the doctor to handle and also for the patient to handle, because we have the comorbidities, we have polypharmacy perhaps, we have impaired cognition, dementia, depression, which probably is there, and that also makes actually a vicious net, and that really makes the life of the doctor and the patient difficult, and also makes the goal of the doctor, the aim to target the HbA1 quite difficult. And the HbA1 target should be stratified according to the frailty of the elderly diabetic patients, and we can really be very, very, very meticulous when we actually dealing with these patients. In order to achieve these HbA1s, we need to use a combination of treatments, and quite often, insulin is actually part of these treatments. And there it comes the dark side of the insulin treatment. Why we need insulin? We need it very well in type 2 diabetes in elderly patients. I'm speaking about type 2 diabetics, actually, not type 1. But what I'm going to say actually applies to both. We know very well that as diabetes progresses, I mean, the function of beta cells really is reduced. So eventually, everybody is going to need insulin. So eventually, as older as we get, the older we get, we will need insulin. So insulin remains, we know that it remains the most effective treatment for diabetes, and is actually quite flexible. But we need to know that insulin has two sides, as everything in this life. Insulin is a high-risk medicine. It can cause significant harm, especially because it can be lethal if it's actually used in the wrong way. So there it comes the dark side of the insulin therapy, which is the insulin dosing errors. I mean, we prescribe the insulin, but sometimes we make errors, or errors are made, as I'm going to say. That's not where we make the errors. And just to go on with this, medication errors is actually a very big issue in healthcare, and that applies to every medicine we give. Medical errors is the 8th leading cause of death in the United States, and it's estimated that approximately 7,000 deaths per year are caused by medical errors, medication errors, not medical errors, medication errors. Insulin, as we said, it's a very, very important treatment, very, very potent drug, but actually it is connected to the medication errors because it's the most frequently cited among the agents who cause medication errors. It is estimated that approximately 30% of the medication errors that are actually reported in the literature are due to the insulin. And insulin dosing errors is very important because it can be lethal, as we said. But how the medical errors come? Who makes these medical errors? In about 40% of the cases, it's prescribing is due to the doctor. The doctor makes the error. As it might sound very, very frightening, but that's the case. We have only about 20–25%, which is concerned about the pharmacist. He can make errors as well. But you see this, about 40% of the errors are actually related to the patient itself. So we have to see this very, very carefully. And let's start one by one. clinician-related errors, prescribing. We prescribe the insulin, we make the dosing errors. And how can a doctor make dosing errors? He can make the error either when he thinks about the insulin and calculates the needs of the patient, so he probably miscalculates the needs of the patients, or he can actually make the error when he prescribes in hand or electronically the insulin itself. And let's take it one by one. Inaccurate carbohydrate counting is one of the most important things and most important risk factors when we actually calculate the insulin we give to our patient. And it's very, very easy to miscalculate the needs of the patient. First of all, the information we get from the patients can very, very often be wrong. The patients cannot really estimate what they really eat, how much they eat, and when they actually eat. That sounds quite strange, but that's the case. I mean, when you ask a patient, most of the cases he will tell you, underestimate what he eats, or sometimes he will overestimate. So the ability to people to estimate the carbohydrate meal content is really poor, very poor. It says here question, but I think it's quite poor. And only 32 of the patients can correctly calculate the total amount of carbohydrates if you have a multi-serving meal. And if you want to ask them exactly what you are going to eat, it's very difficult to have a correct answer. So first of all, the doctor gets wrong information from the patient, and that's one reason he can miscalculate the dose he's going to give to his patient. But secondly, he might have wrong information from the blood glucose monitoring. This is a very, very important thing. Blood glucose meter performance is an important issue in the treatment of diabetes and in treatment with diabetes, especially with insulin. The blood glucose monitoring with the best performance is associated with the most on-target insulin doses. But unfortunately, the meter bias, in theory, a meter bias less than 1% is required to have this on-target insulin dose above 95%. But unfortunately, the level of performance of the meters is really unrealistic, even if we use the most modern meters which are around nowadays, and we have the ISO and all these things. And why this wrong information is coming from the meters? Why we have this? First of all, the meters can be really miscoded. That's one thing. Of course, you can say that nowadays the meters we use are not really coded, so we got rid of this idea, and that's very good. But there are still some meters around which might have the problem. And then if we use the devices which use the interstitial blood glucose, there we have to have always in mind that there is this time lag between the time of the measurement and the measurement we see and the actual blood glucose level in the blood of the patient. And then, of course, we might have a very good meter. The meter is perfect. We have no time lag. Everything is good. But the patient himself might give us the wrong information, either because he doesn't do the frequent measurements as he should do, or he doesn't measure specific times of the day, so he might miss the hyperglycemias or the hypoglycemias, which are very important and actually lead the doctor to wrong dosing. And if the system, the monitoring system is complicated, then the patient really cannot keep up with this and cannot really be able to do it correctly. And never forget that the patient sometimes misleads the doctors. By giving the wrong information himself. You might be presented with a logbook which is totally wrong. And we can always see that we have an HbA1 which is actually quite high. In any case, it doesn't really respond, it doesn't really reflect the blood glucose monitoring you see in the logbook. So that's something we need always to have in mind. One easy thing to do is to ask the patient to see his fingers. Check his fingers. If there are holes or spots, then he does it. But you might see that there is no sign at all. and there is a logbook which is full of blood sugars. The other thing is, I mean, if the patient makes up the blood glucose, the people tend to use the same numbers all the time. So if you see that you have a logbook saying 79, 69, 59, I mean, that means that this is fictitious. That's not real. I mean, he makes it because there is a tendency for the people to reproduce the same numbers all the time. So this is the blood glucose errors, the self-monitor errors. But then, even if the doctor really gives has the right information and he gives the right prescription, I mean the right dosing, he might not write it correctly, and that's very, very often as well. Probably it's really not that often nowadays because we use the e-prescribing, but again, when we prescribe, we just write the name of the insulin or the brand of the insulin. We don't really prescribe the doses. The doses, we prescribe it in hand. So that's where a mistake can be made. So the other thing is the Latin apothecary abbreviations. Apothecary is I mean, it's an old word. We don't really use it actually, but it's a very nice word. And these are prone to misinterpretation. And you can see a tenfold overdoses have resulted from misinterpretation of the abbreviation U for units, because this is thought that it's not U, but it's 0, when it is closely followed by a number of written orders. So we write 40 U, but it can be 40, that is 400, okay? It's 400. Another thing is that when we use the international units, this I can also be misinterpreted, and this can be misinterpreted as 1. So that's another place where actually when we prescribe the insulin, an error can occur. And then sometimes we have, when we fail to write the drug's name correctly or in full, I'll give you, although it's not actually, when we say Humulin, okay, Humulin can be regular, Humulin can be NPH, or when we say we might write Novorapid, Novoflex, or Novomix or Novorapid. I mean, it's easy if we don't really clearly write down exactly the name. This can be misinterpreted as well. So this is the doctor. That's where the doctor makes the mistakes. But also the prescription comes to the pharmacists. The pharmacists can make mistakes. The mistakes of the pharmacists actually are less. You remember it's about 25%, less than the doctors. And it can actually has to do with the abbreviations, as we said before. In another case, the pharmacist does not really translate the prescription of the doctor very well. And also, when he picks up the bottles of the packaging, if the packaging is quite similar, it's easy for the pharmacist, or quite easy, to pick up the wrong box. So an error can be occurring in this case as well. And then we have the concentrated insulins, which actually it's not the pharmacist's fault, but sometimes that can be a case as well. So the doctor says, let's say, well, they have different names, and I don't want to use the names at the moment, but it's very easy to pick up from the shelf the wrong package of insulin. And then we come to the patient, because actually the patient plays a very, very important role here, because the patient is older, and because he's older, he actually has many, many difficulties. So if the self-administration errors are easy to make, especially because this insulin self-administration process, when it is done by a vial and syringe, as it was before, and the patient is older, it's very difficult to make a mistake in all these steps, and especially, and then to this step as well. And then we have how to inject exactly how to inject the insulin, the injection technique. We heard very well from Dr. Vasilatou before how important is the technique and how important is the injection site. And so if the patient, it's very, very easy to make all these mistakes. And going on, have always in mind that we are dealing with an older patient with comorbidities, which has dementia, vision loss, neuropathies, poor motility, poor manual dexterity, and all these things can really affect the ability of the patient to self-inject the insulin because either cannot really dial the number correctly or cannot really press the button correctly or cannot actually use the area he should use because actually he cannot really move freely his arm. Of course, with the conventional insulin delivery, this was more prominent. Now we have the pens. Things are much, much better because pen devices have been shown to provide more reliable, accurate, and simplified dosing, and therefore are safer. But still, we have to have in mind this. Patients do prefer the pen devices because they eliminate the need of drawing the dose. They have greater accuracy and reliability, especially at low doses. Just imagine that you need to draw up 2 or 3 through units in a syringe. I mean, it's impossible, even for a patient who is quite young with very good vision and very good manual dexterity. When we use the pens, because we have the click when we dial the numbers, I mean, that really helps the patient, especially if the vision is affected. And also because they are more compact and it's more easy to grip, and you can use just one hand or probably the second, but it's more easy than to use the pen and to press the button for the injection when you use the syringe. But we have to know that, okay, pens are fine, but there is an error here, which is quite often. The pens, they need to be primed before use, because always there is a small, they have an air shot, as we say. You need to dispense some units before you start using the pen. And that's an error which actually has to do probably with the doctor, the pharmacist, the nurse that really educates the patient. But that's an error which is very, very often, because in this way, if you don't prime the pen, it's very easy to make an error when dosing the insulin. And finally, just to finish, we discussed all these things about having in mind the outpatient, the person who is at home and who is actually taught how to deal with his insulin and give his shots. But when we come to the hospital, things are not really that better, because these errors, dosing errors, can always be, again, when you have an inpatient setting, a hospital patient, because various types of the error are associated with the insulin use. And also it has to do that insulin is given to the wrong patient. We've heard that quite a long time. The formulation might be wrong. I mean, the medication might be wrong. And sometimes all the other things we discussed about the prescribing, the type, the abbreviations, the Latin apothecary, and all these things also apply to the hospital setting as well. And we must always forget the ones who are working at hospitals, that the patient who comes in and who is going to stay for a couple of days, hopefully, and not for long, he knows better his diabetes than we do. So it's always good to have in mind that when he suggests something, we need to listen to him about the dosing, about the time he used to do it, first of all, and also to give the patient the opportunity, and if, of course, he has the ability, to do the insulin injections himself. Thank you for your attention. I have the 2 cases, if there is time. 75-year-old woman, type 2 diabetes, well controlled with oral antidiabetics. She presented actually with hypoglycemic episodes, especially when fasting. When we asked for her medical history, she said that 2 months ago she was diagnosed with temporal arteritis, and she was given prednisolone, along with the advice to add basal subcutaneous insulin, 25 units, once a day to her anti-diabetic regime. She was doing well until a month ago, when she started tapering the cortisone dose as instructed. So what was wrong here? Whose mistake? Who made the mistake here? The doctor. He should have told the lady that as soon as she tapers the prednisolone, her needs will be down, and so she should taper down the insulin and probably stop, or go to the doctor quicker. The second case, so poor prescribing information, that's the doctor here. 68 years old woman, type 2 diabetes with rheumatoid arthritis. She's on insulin treatment the last 7 years, basal insulin once a day. She recently had an eye cataract operation, and because her diabetic control was not adequate, she had an HbA1c of 9%, with high postprandial blood glucose. She was given short-acting insulin 3 units before its meal and told to lose weight. And she comes to you having lots of hypoglycemias. But apart from the reason she comes to you, what's the mistake? Where is the error in this case, and who made the error? I think, first of all, we should have told her to assess the blood glucose. I mean, we just told her, okay, you have high postprandial blood glucoses, take some quick-acting insulin. And that's all. I don't think that's the case. I mean, we need to explain. 3 units, why 3 units? Is it enough? It might be little, it might be more. I mean, we had to explain to this lady more. And then we had to tell her when and how to do the insulin administration, not just give her the prescription, okay, do this prandial insulin, because she already was on insulin, so we assumed that she knew how to inject herself. We just prescribed the quick insulin and left her on her own. That's not true as well. That's not good as well. And then we have to take in mind that she has a poor vision. She just had cataract operation. I mean, her vision is not good, especially in the beginning. And she has rheumatoid arthritis with really limited manual dexterity. So we have to have this in mind before we have a complicated regime in a lady like this. Thank you very much.
Okay, thank you.